The following is a presentation of the Dental Auxiliary Programs in the Department of Health Careers at Lansing Community College. This videotape will illustrate and demonstrate the posterior CURET instrument.
CURETs are instruments used to remove supragingival and subgingival deposits, final scale all tooth surfaces, plain root surfaces, and perform soft tissue curettage. At this time, you will be learning to use the posterior CURET for the purpose of scaling. As with the anterior CURET, the posterior CURET has the same working end design. The working end is spoon-shaped and in cross-section is a half circle or crescent shape. The working end face of the CURET joins with the curved lateral sides to form one continuous cutting edge. The lateral surfaces converge to form the rounded base. Notice that two of the portions of the cutting edges are parallel, joined by a round tip. This shape must be maintained during instrument sharpening. The parallel portions of the cutting edge can be further divided into the upper, middle, and lower thirds. The lower third, also called the side end, is the portion of the cutting edge which must be adapted to the tooth surface at all times. First, locate the two parallel portions of the cutting edge and identify each as the inside or outside cutting edge. The inside cutting edge is located on the same side of the instrument as the inside surface of the shank's angle. The outside cutting edge is located on the same side of the instrument as the outside surface of the shank's angle. Like the posterior sickle, the posterior CURET is a paired instrument with each end being a mirror image of the other. It is supplied in your instrument kit as a double-ended instrument to help minimize the number of instruments required on your tray setup for a complete prophylaxis. The shank of your posterior CURET is angled, allowing easy access to the posterior teeth. Because this is a paired instrument, you will have to determine the correct end to use for each sequence. To select the proper instrument end, first place the instrument supragingivally, interproximally, and on the distal surface of a posterior tooth. Second, if the shank is parallel to the long axis of the tooth and the base of the working end is directed apically toward the gingiva, then you have the correct end for that sequence. You are now ready to begin practicing sequence 1 with the posterior CURET. Start with the most posterior tooth in the sequence using the facial aspect. Remember, the posterior sequences begin with the most posterior tooth in that same quadrant and continue forward to the canine. After establishing a proper grasp and fulcrum and selecting the correct end, place the lower third of the inside cutting edge on the distal line angle. Place the shank parallel to the long axis of the tooth. Then tilt the shank slightly toward the tooth surface you are working on. Close the face of the working end to the tooth surface and insert the working end subgingivally to the epithelial attachment. When you reach the base of the sulcus or pocket, open the face of the working end to an angle greater than 45 degrees but less than 90 degrees to the tooth surface. Now, using a vertical exploratory stroke, move the CURET around the line angle until you reach the area just past the midpoint of the distoproximal surface. While maintaining your fulcrum, remove the instrument from the sulcus and tooth surface. Replace the instrument on the distobuccal line angle using the outside cutting edge. The shank should be made parallel, then slightly tilted toward the tooth surface. Continue with a vertical stroke to the buccal, mesial buccal, and then the mesial surface just past the midpoint. Remember to keep the shank as parallel as possible to the long axis of the tooth for proper cutting edge adaptation. Remove the curette and proceed with the rest of the teeth in this sequence, facial aspect. It is especially important to curette proximal surfaces because subgingival deposits occur more frequently here and are also the heaviest. Problems of access and adaptation make these surfaces especially difficult to thoroughly scale. A common instrumentation error is not extending the curette past the midline of the proximal surface during instrumentation. It is essential that your strokes extend from the base of the pocket to the contact and that your strokes overlap the mid-proximal area from both the facial and lingual aspects. Proper extension of the working end of the curette can be helped by watching to be sure the shank is parallel to the long axis of the tooth and the side end of the cutting edge is always adapted to the tooth surface. When you have completed the facial aspect of the sequence, move to the lingual. On a patient, you will also need to use a mouth mirror for tongue retraction. As you proceed subgingivally around the teeth, be careful to avoid pushing the working end too far apically into the epithelial attachment. Use a light grasp and gentle vertical walking stroke so you can feel the resistance of the attachment. Remember to always close the instrument face to the tooth when inserting the working end in order to minimize trauma and discomfort. Once the epithelial attachment is reached, the face of the working end is placed at a 45 to 90 degree angle to the tooth surface. This angle provides the most efficient use of the cutting edge for the removal of deposits. When scaling, the angulation of the instrument on the tooth should never be less than 45 degrees. At this angle, the cutting edge tends to slide over the calculus, leaving a burnished or smooth deposit. If the angulation is more than 90 degrees, the opposite cutting edge would be adapted to the soft tissue, causing trauma and discomfort. At this time, practice only your exploratory stroke. You will learn a working or scaling stroke in clinic. Continue to practice with the posterior curette on sequence 1 using the technique you have just learned. Check for correct end selection and cutting edge adaptation. As with all instruments, continue proper instrument grasp, stable fulcrum, and gentle vertical exploratory strokes while practicing.